often we talk about and emphasize the need for a careful evaluation and management of hyponatremia, especially if it's chronic. But often we tend to consider that it may not cause too much harm. We'll be discussing about a case which is not an unusual scenario, a common scenario of long-standing hypoparathyroidism. About tonicity and osmolality, these are two important terms. So osmolality means the number of osmoles which are present in the body. They include the sodium, glucose, and urea. Now, the difference between osmolality and tonicity is that basically sodium and glucose cannot really cross the cell membrane. For sodium to cross, there is already a sodium-potassium ATPase. For glucose, you will need insulin. While urea can freely cross. So urea does not contribute to the tonicity of the plasma. So the major determinant of tonicity is sodium and glucose. While if you talk about glucose, the levels are usually normal. So in the absence of hyperglycemia, sodium is the major determinant of our body tone. Now, in conditions like hyponatremia or in scenarios in which you have an AVP excess, and we discussed that any scenario in which you have got chronic hyponatremia, you will have an excess of arginine vasopressin. In those scenarios, you will have a decreased tonicity of the blood. So the brain cells will basically have a swelling. So they will go into a edematous phase, and that causes all the features: cerebral edema, headache, irritability, seizures, and other problems. Now, to counter that, of course, body does have a mechanism in the form of idiogenic osmoles, which are basically extruded, and through that we are able to save all these problems to happen. There is an adjustment which happens. If there is a rapid rise, however, in the serum sodium, this adjustment becomes maladjustment, and that may cause a problem. And we have been hearing about this since medical school, the term which was earlier known as central pontine myelonolysis, and now we call it more appropriately the osmotic disequilibrium syndrome. So your whole cells will basically, which are swollen, then become normal, will suddenly shrink. So you will have a lot of lysis of these cells, and that causes this myelonolysis. So we'll talk about this is the fundamental aspect which we'll discuss as to how this happened in this case and how we could have prevented, how we could have improved in terms of outcome in that regards. Now, all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources related to pediatric endocrinology courses, including fellowship and diploma programs. We routinely run multiple programs in the form of postgraduate lecture series, grand rounds, their publications, as well as the mobile application. So today, we are going to discuss about a very, very interesting case. Dr. Dhwani, who is our fellow, will be discussing about how this case presented and what it looked like, a normal scenario, and how things changed. Then we'll discuss about what went wrong, and Dr. Manoj will talk about the overall reasons that went wrong and how we could have picked it up at an early stage. Then we have got Dr. Santosh, who is visiting us from Trivandrum, who will be talking about how imaging or other diagnostic measures can help it out. Then we will have a discussion as to what are the measures which could have prevented and how we could have treated in this case by Dr. Vibha. And finally, we'll bring everything together to see how this case management could have been better from that perspective.
We had Mrs. M, who was a 40-year-old female who presented to us with loss of appetite for 20 days, lethargy, weakness more since the last 20 days. On inquiring further, we got this history of stillbirth at 22 years of age with history of secondary amenorrhea since. There was history of decreased interest in activity, lethargy, poor sleep quality for the last 20 years, ever since she had this stillbirth.
So I think that's a very, very important history that you've elicited there, that at 20 years of age, she had a stillbirth, and after that, she had secondary amenorrhea. Now, one question which will really help you out reach a final diagnosis is, what would you ask at this point, which will tell you that this is really the diagnosis you're looking at? First, what diagnosis are you looking at, and what single answer will give you a final diagnosis there?
So if she had lactation failure,
yes,
in the immediate or postpartum hemorrhage, if they give a classical history of having bled a lot, then that will really clinch the diagnosis.
So this is clearly what you think. This is a Sheehan syndrome classical presentation, a patient who actually had a delayed overall problems in terms of the postnatal period. And the key question, as you said, would be to ask whether there was a lactation failure in that scenario. So now you have all these features are suggestive of a classical low level of cortisol deficiency. So let's continue from there.
Yes, so all of her symptoms were attributed to clinical depression, and she was somehow started on antidepressants, which she had been taking for the last 6 months with no significant benefit in symptoms. For these complaints, she had also visited our OPD about 10 days back. Because the symptoms were non-specific, she was advised some blood tests which showed microcytic hypochromic anemia with thrombocytopenia. Her rest of the investigations were predominantly normal. She was sent on some oral supplements. However, as symptoms persisted, she reported to the emergency room 10 days later.
So who was the primary, like which physician did she go into, which specialty in the beginning?
She went to the cardiology department.
Okay, so because of this lethargy, weakness, they went to the cardiology department. Now, again, they have done basic workup, which shows anemia and thrombocytopenia. They have done a TSH as well. What do you think is the thing which you would have done better at that point of time?
It is always necessary to look at the free T4 level in the context of TSH level.
So just doing a TSH, definitely again, second message coming up here that if you just do a TSH, you may miss a lot of problems in that. And the other big message, what was missed here was serum electrolytes. So routinely, if you have somebody who is lethargic, weakness, you should look for electrolytes as well. Yeah, please carry on.
At presentation to ER, her heart rate was on the lower side at 64 per minute. Respiratory rate was 18 per minute. She had cold peripheries and BP of 70/60. She presented to us in a confused state with slurred speech. However, her sensorium was E4, M5, M6, V5, and pupils were 2 millimeters bilaterally equal reactive to light. She had slightly brisk DTRs with mute planters and blood sugar on the lower side at 66 milligram per deciliter.
So there are two big messages that you're giving. There is bradycardia, which is there, and there is hypoglycemia. So hypoglycemia and bradycardia, what would you think of?
Hypocortisolism is somewhere.
So hypocortisolism means multiple pituitary hormone deficiency because you have a thyroid probably affected. Now, of course, we know the diagnosis, so we are more biased. But if you have somebody who has got hypoglycemia with all that presentation and who has bradycardia, we are thinking clearly of a MPHD. Carry on.
So this was the initial lab investigation when she presented to the ER. So again, we had a hemoglobin of 10.5, sodium of 100, and a potassium of 2.9. The rest of the investigations were essentially normal. Again, only TSH was done at ER, which was in the normal range. She had a slightly elevated SGOT level. But the most important or most worrisome thing that I find in the initial lab is her sodium of 100 against a potassium of 2.95 here.
So I think this is a very, very starking report. Now, we normally say when you have hyponatremia, sodium and potassium usually go the opposite way around. So if you have hyponatremia, you will have hyperkalemia. If you have hypernatremia or high normal sodium, potassium will go down. What are the conditions which cause hyponatremia with hypokalemia, Dhwani?
So adrenal insufficiency is something that will cause hyponatremia with hypokalemia.
Adrenal insufficiency in the sense, so if you have primary adrenal insufficiency, we expect to be hyponatremia and hyperkalemia. That will be salt wasting. So generally what we say is that when you have both low, you are losing. So you're losing either from the tubules, diuretic use, or you have a gastrointestinal loss. Now the question is that if you are attributing it to adrenal insufficiency, is it central versus peripheral? What do you think based upon this sodium report?
Central, definitely.
Central, definitely, because the potassium is normal. Now, the extent of sodium reduction is very, very remarkable. So I think that's something which is another thing to really consider, because as we discussed that when we compare three classical scenarios, if we say isolated glucocorticoid deficiency versus isolated mineralocorticoid deficiency versus a combined defect, which one of these has a maximum effect in terms of sodium levels? Which one of them the sodium is the lowest?
The combined one usually.
Yes, because 100 is too low. That is something which I would be a bit too. I have seen hundreds predominantly in adrenal insufficiency, in CAH, that sort of a scenario. So this 100 was extraordinarily low. The second thing is that potassium is also low. So normally they have a normal potassium, but of course, if somebody is not eating well, somebody is malnourished, you may have some level of hyponatremia, hypokalemia, which may happen. Can you think of any other thing you have already mentioned in your history that could have affected her sodium levels to be that low? besides the cortisol deficiency. There is, of course, hypothyroidism also. So that also contributes to deficiency. But this 100, anything else? You gave a history. So that she was on some antidepressants. Now we know that many of these antidepressants do cause SIADH. Like
SIADH, yes.
Now, if you already have cortisol deficiency, if you already have hypothyroidism, on top of that, there is an antidepressant which is further increasing ABAP. Of course, the sodium can be explained. So this very severe hyponatremia is unusual. Typical sodium that you will see in ACTH deficiency will be like 120, maximum 115. I have not seen anything below that. But this 100 is a very, very remarkable, but may have been given antidepressant which could have affected. Sometimes diuretics are given along with that. So you have to be careful about all that. Drug history becomes important. So now you have got an individual who has got 20-year-old history, a long-standing disease. Suddenly, the patient comes to you with a sodium of 100. Now, what do you need to understand here is that this patient has been living with this condition for 20 years. It's not that she is in a life or death situation. That is what is very, very important to understand. So don't be too aggressive. Now, remember, this patient was admitted under cardiology. So had they been admitted under us, we would have been more cautious in terms of rise, but they would have seen 100 and they become a bit that something needs to be done immediately. But they haven't thought that for 20 years, the patient was normal and why suddenly we have to worry so much about that. Carry forward.
So let us look at the approach to hyponatremia. When you have a patient with hyponatremia, the first thing to question is it true hyponatremia? Hyperlipidemia, hyperglycemia, and hyperproteinemia. All these three conditions are associated with pseudo-hyponatremia. So the first step is excluding these three. The next thing to ascertain is whether hyponatremia is due to excess fluid or sodium loss. So once we know it is true hyponatremia, we need to know whether it is because of an excess fluid or sodium loss. In a status of free water excess, patient will usually be U or hypovolemic, whereas those with sodium loss are usually hypovolemic. Uric acid is low in free water excess and high in sodium loss. Similarly, hematocrit is low in free water excess and high in sodium loss. Urine sodium is low in free water excess and high in more than 25 in sodium loss.
So clinically, was she euvolemic or hypovolemic or hypervolemic? Because volume is the most important thing to look at in hyponatremia. What do you think clinically she was?
At presentation, she had good pulses, although her BP initially was recorded as 70/60, but subsequently, after giving a single bolus, she had remained in a euvolemic state despite having this hyponatremia.
Pretty much euvolemic. So she was not really hypovolemic. So all the insufficiency part, sodium loss part is lost. Now, when you say euvolemia, actually, if you measure their blood volume, you will find them to be subtle hypervolemia. Now, whenever your volume goes up, what will happen then? Which hormone will get triggered?
Aldosterone.
No, volume is up.
Yeah, AVP.
ANP, atyl natriuretic peptide. So basically the heart will say my volume is up, I'll push the sodium out. So that also will further contribute to hyponatremia. So you get the point? In that scenario, your fluid volume, you have more amount of free water in the body. That free water increases relative hypervolemia, and that relative hypervolemia triggers ANP that causes sodium loss and you become euvolemic. So when you are saying SIADH or hypothyroidism or ACTH deficiency as euvolemic, they are truly hypervolemic, which have compensated into euvolemic in that scenario. So I think this was very clear, and this patient had a mild anemia. So there was no hemoconcentration definitely. So you're talking about mostly a euvolemic hyponatremia. Next, please.
So after we've seen the fluid status, if it is hypovolemic, we need to rule out congestive heart failure, chronic liver disease, or nephrotic syndrome. In patients with euvolemia, the most important thing is to see free T4 level and cortisol levels. If these are normal, then we're looking at a patient with SIADH.
So one big message is that whenever the intensive care specialists see hyponatremia and patient is not having hyperkalemia, is euvolemic, they label it as SIADH. SIADH is a diagnosis of exclusion. SIADH basically means you have got dilute blood and concentrated urine, opposite of DI, dilute blood, concentrated urine with a normal renal thyroid and adrenal functions, and no history of uptake of diuretics. So all these are confounding factors. So clearly we are out here. Fluid status is euvolemic. You need to do a thyroid profile and a cortisol before you go ahead any further. And we have mentioned FT4. That is again a message that this looks like a central scenario. So please go ahead.
And in hypovolemic patients, one needs to look at the urine sodium. If it is more than 30, if it is less than 30, then we're looking at GI losses. If it is more than 30, then we need to look at the serum potassium level, which if low, we're looking at kibulopathy or diuretic use. And if it is high, we're looking at RAS defect. So we went on to the further investigations, and we found that the serum cortisol at 8 a.m. was definitely low. TSH was normal in the background of a low T4 level, and LH-FSH were again in the lower for postmenopausal age.
So now when should you do this cortisol level? Should you do it in the morning?
Because we want to document a low level, we would like to do it at 8 a.m. Okay. Like we are expecting a low value. So
suppose somebody has come to you at 10 a.m., you will say, I'll check it at next 8 a.m.
No, we can.
See, this patient is hyponatremic. So if you have hyponatremia, if you have shock, if you have hypoglycemia, already the ACTH is very high. So you don't need to actually wait till 8 a.m. So this is all the cardiology workup that they have done. We would have said immediately get a cortisol level, get the report in an hour, start hydrocort, because we know the diagnosis very, very clearly. So you don't need to wait till 8 a.m. That's a big message. Otherwise, you will be wasting a lot of time in that perspective. So if there is shock, if there is hyponatremia, if there is hypovolemia, if you have got hyponatremia, you should get a cortisol level immediately, and that will be fine. Now this 88, Dr. Manoj, what do you think? This 88 is low, but how low is it?
So the normal level is 130. And at the higher ACTH level, and the background of the
so how much should it be? Would you find it to be normal? Yes, so at least it should be 500, 550. So this 88 is very, very low. And what about the thyroid? Clearly, FT4 is pretty low and TSH is less than 20. So this is a classical case of central hypothyroidism. Now, the one point which Dhwani has very nicely pointed out is that LH-FSH was normal. Now, this is a lady who was not having any periods. So not having any hormonal development in LH-FSH is normal is inappropriately low. So this is classically a multiple predatory hormone deficiency. Please go ahead.
So in our database, we have a 42-year-old female presenting with secondary amenorrhea after a stillbirth with progressive lethargy since then. On examination, in a predominantly euvolemic state with subtle features of raised intracranial pressure, and on investigation showing hypoglycemia, hyponatremia, hypokalemia with central hypothyroidism, cortisol deficiency, and low LH-FSH. So we pretty much have the picture. This is hypopituitarism secondary to Sheehan syndrome.
So now, just before you go ahead, now, how would you classify the severity of hyponatremia? Is it acute, severe, acute, moderate, or this is chronic hyponatremia? How will you classify?
This is definitely chronic hyponatremia.
And definitely anything which is beyond 48 hours, we call it chronic. And here the history is so long. So this is of course chronic. And if you don't know the history duration, you assume it to be chronic. I think that's the key message when we are starting treatment again becomes important. Please go ahead.
So management of hyponatremia based on symptoms, it could be acute, severe, where the sodium level is usually less than 120. Here you give 3 to 5 ml per kg, 3% saline bolus until symptomatic, and you target a rise in serum sodium of not more than 12 millimoles per liter per day. Acute moderate is sodium between 120 to 130. In this condition, you avoid bolus and you target a rise in sodium of 6 to 9 millimoles per liter per day. And then comes the chronic variety where no acute treatment is needed and you target a rise in serum sodium of not more than 6 millimoles per liter per day.
So this looks like the chronic state. But if you have subtle features of CNS involvement, like you were saying, brisk reflexes, raised DCTRs, you may consider a low dose 3% saline in that category of chronic as well. But again, low dose, not like a high dose. Now, what actually happened from the cardiology perspective? What did they do?
Yeah, and while it is important to target a rise in serum sodium, you must always even treat the underlying etiology in these cases.
Yeah.
So what happened in the index case was, for hypokalemia, her ECG was normal and she was started on potassium supplement. For hypotension, she received an initial bolus, following which she remained euvolemic and was well otherwise. On the hyponatremia front, she was given 3% saline bolus followed by infusion along with aldactone.
So what do you think? How do you assess this? So of course she was given 3% bolus, which we may consider okay, but 3% infusion clearly is a problematic issue. How much sodium increases with every 1 ml per kg per 1 ml per hour of sodium infusion, 3% saline infusion? So 1 ml per kg per hour of infusion, how much sodium will increase by that?
I'm not aware of
Roughly 1 millimoles. So she was, I think, on 50 or 25. How much she was on per hour?
25 ml per hour.
25 ml per hour. So she was like 0.5 millimoles per ml per kg per hour. That would have rose by at least 12 in a day. So that was going to in a very, very wrong trajectory. We don't want it to go beyond 6 or 8. Now, aldactone. Now, what would aldactone do? Vibha.
Basically,
Yeah. Vibha, what will aldactone do? No, it antagonizes what? It is against what? It is a mineralocorticoid receptor antagonist. So your glucocorticoid is already not there, and then you are also blocking the mineralocorticoid, not the RAS, mineralocorticoid receptor. So your glucocorticoid is already not there. If you're going to block your mineralocorticoid, you're going to cause hyperkalemia and you're going to worsen your hyponatremia. So probably this is a bit preposterous to say, but probably aldactone did not allow the sodium to rise that much as it would have risen had they not given aldactone. So it might have been pulling it down. So it was so both are inappropriate, but this could have balanced it out because this could have not allowed sodium to go up that quickly. But that definitely is no physiological basis of either of those treatments. Yes, Dhwani.
So what happened was, with this treatment, serum sodium rose rapidly from 100 at presentation to 122 within 36 hours of hospital stay. It was at 36 hours of hospital stay that finally an endocrine call was given when 3% saline and aldactone were finally stopped and the patient was started on injection hydrocortisone.
So by the time this is a very good graph. You can continue. Yeah.
So this, as you see, the serum sodium had risen from 100 to a very rapid rise of 122 at 36 hours of hospital stay. And why associated with this rise in serum sodium, we found the patient to have a clinical worsening in form of meaningless muttering, a start of chorioathetoid movement, worsening of slurring of speech. She was unable to sit up straight and was constantly rocking in her bed. There were intermittent episodes of vacant stare with drooling of saliva from the angle of mouth.
I think that's very important to remember and understand that many of these patients have been so sick for such a long time, nobody knows what their normal state is. Some people say they are like this. Ye to aise hi the, shuru se. So these signs you have to be very, very careful. So when we saw this patient at 36 hours, already the sodium was 122 to 124. We said, okay, no further rise at this point of time. And we were looking for all those things. There were some subtle features, but by next day morning, I think probably another 24 hours passed when all this night sleep abnormalities, continuously fidgetiness, abnormal movement, and subtle signs started to creep up. So this is something which, if we had picked up even earlier, that would have been better. But again, they are very, very subtle and often difficult to pick up, in which the sodium was very low to begin with. And then subsequently, there is a sudden rise. And what we are seeing probably around 36 or 60 hours, that there are certain signs which are happening. Now, first of all, we need to know what these signs are and why are they caused. So we will.
So now looking into the topic, what is the osmotic disequilibrium syndrome? So in this defect, mainly brain is affected. And what are the part of the brain mainly affected? That is the brainstem. And what is the importance of the brainstem? Brainstem has the pons, midbrain, and thalamus. And pons is very important point. It conveys the all message from the peripheral to the central vision. It takes all the sensory and motor sensation and it convey to the cerebrum. So if pons and the peripheral pons tissue is affected, then we have some kind of spatial symptoms that we will see in this topic. So in osmotic disequilibrium syndrome, there is a both chances, pontine and extra pontine involvement will be there, and symptoms are different for the both. So what is the really central pontile myelinosis? So it is the involvement of the central nervous system, which cause the pontine and the extra pontine involvement, and this occurs typically due to the osmotic changes. It is not due to the inflammation, or it is not due to the infection. So here the dehydration caused the myelin sheath breakage, and it's caused this typical symptom. So if we see, then this patient have some lucid interval. So in the beginning, our patient was asymptomatic. We were happy that patient was recovering. And after this, some 1 to 2 days, usually patient worsening will be there in terms of the 48 and 72 hours. And there will be, if we don't treat at the particular time, that patient may have the gradual progression which cause the coma and death. So what are the functions of the pons? Pons is a major part of the brain which links the brain with the spinal cord, and it have the major two pathways that we are discussing mainly. One is the corticobulbar pathway which take the information from the periphery to the brain. And why it is important? Because it regulates the muscle movement of the face, neck, and the speech. So if this corticobulbar pathway is affected, then our speech will be difficult, our facial movement will be affected. And second part is the corticospinal pathway. Why it is important? Because it conveys the all information from the brain to the motor tissue. So if this pathway is affected, then we have the extrapyramidal symptoms like Parkinsonism. So firstly, in all osmotic disequilibrium syndrome, corticobulbar pathway involved, and if we don't treat, then there will be the involvement of the corticospinal pathway. So what are the main function of the pons? It regulates our sleep cycle. It regulates our pain signal. It regulates our movement and the balance. And fourth is it regulates our respiration. So if pons is affected, then in this case, what are the main symptoms? Patient may develop the altered sleep cycle followed by the dysarthria with the decreased pain sensation. And if we don't treat, then involvement of the corticospinal and bulbar tract will be there, and it causes the dysarthria, dysphagia, facial paralysis, loss of the balance, coordination, and finally quadriparesis. And finally, there is a state of the locked in state that where patient can't able to it is in locked in condition. So
they will basically be looking at one side. You will feel that there is a sensory, but they are not responding. And they're not behaving. So I think most important point which you said is the sleep cycle. So always when you have this sort of cases, ask them to a good history whether they have been able to sleep or not, or whether they had a very disturbed sleep. That is there. The second thing, of course, is the abnormal movement, that they are rhythmic sort of movement which appear, which is a bad sign at that point in this area. So speech, movements, and sleep, these three will be the major things to look at.
And finally, if we don't treat this patient at the right time, then it may end up with the arrest, coma, and death due to the respiratory center failure. So in our patient, firstly, as sir greatly explained, that will be the altered sleep pattern. So in this patient, sister has given typical history. There raat se soi nahi hai. Like there was a typical history of altered sleep cycle, and there was a dysarthria followed by. So in our previous case also, there was a similar history. There was an altered sleep pattern and dysarthria was there. And finally, our patient has some another moments. So we will discuss it later. So what are the etiology for the development of the osmotic disequilibrium syndrome? So as sir told, any cause of the rapid correction of the chronic hyponatremia. Hypokalemia also can cause the osmotic disequilibrium syndrome. So what are the causes?
If you have associated hypokalemia, they tend to do worse.
Yes.
And this is the point which is important. In this case also we had hypokalemia.
Yeah. So what are the causes of the chronic hyponatremia? So if we compare about the adult and adolescent age, then chronic alcoholism, chronic liver disease and malnutrition was the biggest factor that has been reported till date. So in our patient, there was a malnutrition was there and hypokalemia was there. So it was a triggering ODS. And if the patient has a multiple pituitary hormone deficiency in the diabetic ketoacidosis, and if patient went into the dialysis, that caused the ODS to develop. So in our patient, there was the MPHD was there, Sihan syndrome, malnutrition was there, hyponatremia was there, and hypokalemia was there. So it was C has high chance of the development of the ODS at that time. So according to case reports, which what I likes to highlight, in the diabetic ketoacidosis, generally cerebral edema and hyponatremia occur. But this case has been reported in the USA, and where the cerebral edema was treated, there was a bicarbonate induced cerebral edema, and in that case they gave rapid correction and they developed with the ODS.
So this is a very important message. In cerebral edema, what is happening in diabetes, you have actually the hyperosmolarity. Hyperosmolarity, rapid correction causing cerebral edema. Now, if we become too aggressive and treat cerebral edema aggressively, we can again go into the same scenario. They are doing the same thing. We can cause a shrinkage. So we should be preventing both the not treating too much diabetes, not treating too much edema. So a lot of people we have seen now is that if there are no clinical objective use of cerebral edema, there is a child is looking sick, he must have cerebral edema, let's give the manager. That also should be avoided. So you need to be very, very careful that you have got specific criteria. Use criteria is followed and don't be too aggressive. So what happened here, that first the patient was having a shrinkage. Then because the treatment became edema and then again shrinkage. So this of course will be a very, very bad scenario.
So important message from this case report was that if you treat, if you give unnecessary fluid, if we correct the cerebral edema inappropriately, then it can cause the ODS. So patient may have some complication. So finally, if we discuss about the what are the symptoms that the central pontile myelinosis, as we discussed, a patient initially may become asymptomatic. So there could be the lucid interval. So in that time, if we have the risk factor, then we have to be worried. We have to keep watch on the sleep cycle and the specifically of the dysarthria, because if we don't keep watch on these symptoms, then patient may have some another symptoms. So patient may have asymptomatic clinical stable interval followed by the ODS induced deterioration, which takes 1 to 4 days, and followed by encephalopathy, loss of memory, dysarthria, dysphagia, and altered sleep pattern. If we don't treat at the right time, then patient will end up with the flaccid and the spastic paralysis, followed by lock-in syndrome and the death. These are the symptoms if the pons is involved. But nowadays, because of the MRI is easily available, so in the literature they found that there will be the extrapontile association is also there, so which affect the mainly extrapyramidal symptom, which affect the mainly movement and the balance. So in this patient, the dystonia, myoclonus, rigor, and the atypical movement we can find, and finally it can cause the ataxia.
I think this is important because when we discussed with the neurologist,
Yes.
when we were thinking of what can be done, we were thinking how bad is the situation, whether it will improve or not. So he said this looks more like an extra pontile rather than central pontile. This gives us a way to go more aggressive in terms of treatment.
So if we compare both the symptoms, then they both have some general symptoms, which is encephalopathy, seizure, mutism, apathy, and lethargy. If we compare about the cerebral pontile myelinosis, then the locked-in stage, dysarthria, dysphagia, and the coma will be the prominent symptoms. And in the case of the extrapontile myelinosis, tremor, dystonia, chorea, myoclonus, and movement disorder will come place. So in our patient, we have found some choreoathetosis and some tremor was there. Mainly movement was affected mostly. So as sir rightly told, our patient had an extrapontile myelinosis. So in our patient, there was an involvement of the extrapontile involvement. So whenever patients come with this kind of symptom, then initially why we have to take care, because initially we have to rely on the clinical diagnosis. If that time, if we do MRI or CT scan, then it could be negative. So we don't have to rely on the MRI and the CT scan on the initial basis. We have to diagnose the patient on the clinical basis, and it is important because if we take appropriate therapy for that time period, then we can survive the patient. So according to literature, most ODS reported has been in India is reported by the hyponatremia followed by the hypokalemia. If there is a hyponatremia and hypokalemia is there, then chances of the ODS will be more. And what are the initial symptoms that we generally see? Generally, we see encephalopathy at the presentation in the season, and followed by some extrapyramidal symptoms if extrapontal myelinosis is there. So nowadays, because of the easily availability of the MRI, the central extrapontal myelinosis is coming more than the pontal myelinosis.
So now again, we have already discussed in this case how there was problems in there. So Dr. Dhwani, you are there?
Yes, sir.
So what really do you think should have been done here?
So while we should have given DDAVP along with 3% saline at the very outset itself, we definitely got late. After starting injection hydrocortisone, she had shown slight improvement initially, and then we got this history of altered sleep cycle and dysarthria. So that is when ODS had actually set in this patient. And we went for the rescue therapy in form of free water and oral desmopressin. But even with this, we were able to achieve 5 milliequivalent per liter per day fall over 48 hours and a clinical resolution in symptoms.
So that's the key message, that even if you are late, you may get a very good response. So we were able to lower using oral desmopressin and free water. So we gave multiple boluses, Manoj. How many times did we have to give bolus? I think we gave 4 or 5. 5 boluses of 5% dextrose, and to the ICU team, it was looking paradoxical as to what we are doing. Why are we lowering a sodium of 122? But they were not understanding that. But finally, this patient, within a day, we were able to get back out of the ICU. And latest she came to us, she was walking actually. So this is a very, very good, in which the entire team had to work so hard, but it gives a very big messages to everybody. So I think this basically means that when you have somebody with severe hyponatremia, if you are thinking of good correction, rapid correction, give DDAVP at that point of time. Second, if your rise, as Vibha was saying, is more than 8 per 24 hours, give DDAVP then. If you have lost all that, even then, if you give free water, if you give DDAVP, you will have a good improvement, which is there. So I think this was a big message with that regard. So this was in the background of Sheehan. Now she is on hydrocortisone, thyroxine, and we deferred the induction of thyroxine. And we reduced the dose of hydrocortisone because we knew that if we give too much hydrocort, if we start thyroxine, the patient will have a sudden worsening because sodium will go really high. And gradually the replacement was done in that perspective, in that regard. So this was the trend which we saw, and gradually after all that we were able to establish. So